All right, so we'll go ahead and get started. You may have just noticed that the call just started to get recorded. So again, if you do not want to be on a recording today, please exit the call, and this call will be available at a later date on the DDAP ASAM alignment website. But I just want to say thank you so much for everybody for joining us this morning. We already have a really large group, so that's wonderful. We're going to be talking today about individualized documentation and kind of ASAM, what ASAM really has to say about documentation, and maybe some suggestions about documentation. And I just want to give you a couple of reminders that, for these calls, which are offered on the first Monday of every month, we ask that folks submit questions related to the topic 7 days in advance to the RA ASAM email account. And you are welcome today to submit questions in the chat. However, we will not be providing responses in the chat today. We will be making a note of the questions that are asked, and we will post the questions and then the corresponding answers to the DDAP website several days after the ASAM recording or the ASAM technical assistance call recording. So please feel free to type in questions in the chat today as we're having the call, and then we will respond to those at a later date. We're not being rude by ignoring them. We're just trying to save time for the presentation, and we'll address those at a later date. We all know that it's being recorded. And if you have suggestions for future call topics, please submit those to the ASAM email accounts. We always are open to suggestions, and we would love to hear from the field. A couple disclaimers today. So I just want to make it extremely clear that the information that I'm providing today is purely informational, and they are suggestions and considerations, and they're not to be interpreted as required or regulatory. So I just want to make that extremely clear. This is not how you have to do things. These are just suggestions. And we also just want to recommend that people look at the trainings that we have available right now related to this topic. And the one I really want to point out is the treatment planning with the ASAM criteria. So that is a training that's being offered right now by Dr. Martha Thompson and Stephanie Thorne. I cannot recommend this training enough. This is such an important training for people to attend. So if you have not already done so, please sign up for this. And I'm going to be referencing this training quite a few times today on the call. All right, so we're going to be talking about documentation today. I'm going to be starting with the golden thread, and then moving on to the biopsychosocial assessment or the intake and admission, and then treatment planning and progress notes. And finally, we're going to end with a Q&A. So several folks did submit questions related to this topic ahead of time, which was wonderful. And so we are going to be able to kind of broadcast those questions, and we will be providing responses to those questions during the call today. So that will happen at the end. All right, so before we dig in, I just want to clarify that throughout the presentation today, I'm going to be using the term patient most often, and that's not, you don't have to use the term patient, but that's what I'm going to be using most of the time today. And I do want to point out, and I'm going to be pointing out several times today, kind of specific areas in the ASAM text where you can reference things. And I would like to point out that on page 15, ASAM does provide information about their approach to using these terms. And they really do avoid using the terms client, consumer, and customer. So again, this is not how you have to do things, but for the purpose of this presentation today, I'm really going to be focusing on patient, and I might slip up a couple times and use another term, but that's really the term that I prefer to use. ASAM does kind of heavily prefer to use the terms individual, person, patients, and so just want to reference that. Okay, so this golden thread of documentation, for those of you who have attended the ASAM treatment planning training, and for those of you who've been in the field, this is a pretty common term that people use, the golden thread. And so it's a pretty simple concept that really, what it means is that information that's found in the intake and assessment flows very clearly throughout the patient record. So the assessment is linked to the treatment plan and then linked to the progress notes. And the golden thread loops the initial assessment and all additional information into each step of the patient's journey. So the golden thread supports kind of a really meaningful client narrative and highlights the very critical nature of the assessment and making sure that we're not missing anything in the assessment and that the assessment is as thorough as possible, because really everything about the client's or the patient's experience and treatments is then threaded throughout the patient record. So I'm going to be referring to the golden thread a couple times today, but really it is just this idea that what we identify in the assessment is then clearly identified in the treatment plan and the progress notes. And it's very, very clear for somebody looking at that patient record. When I was getting this together, I was thinking about what is the opposite of the golden thread. And I think what that would look like is a patient record that's very kind of fragmented and difficult to follow. And you would maybe open up a patient record and review the assessment, and the problems or strengths in the assessment just cannot be seen in the treatment plan, and subsequently the progress notes and the content of what was covered in session and with homework assignments is not at all kind of tied back to the data that is found in the assessment. So going to be, again, referencing this golden thread quite a few times throughout the session today. So in very simple terms, the golden thread refers to if a problem is identified in the assessment, it's clearly seen in the treatment plan and it's clearly seen in the progress notes. If a new problem emerges during treatment, then this is noted in the progress notes, and then it's maybe you go back to the assessment and it's added, and then it's likely added to the treatment plan. So at the very simplest terms, it's that if a problem is identified in an assessment, it is very easily seen in the treatment plan and in the progress notes, and it's very easy to follow. So I think it's really important to remember that when we're doing kind of the assessment, we don't forget the strengths or those protective factors. And these also should be woven throughout the patient's record as well. So I think we really have to build off of these strengths and protective factors and weave them throughout the patient's treatment. And it should be very clearly seen, woven throughout the assessment and the treatment plan and the progress notes. And I also want to point out that, in remembering to include strengths and protective factors, it's, I think a lot of us understand this, but when we're working with people who have, trauma or decades of substance use or incarceration or poverty, if you ask them, hey, what are your biggest strengths? This is actually a really hard question for a lot of folks, and it can actually be quite triggering. It can bring up a lot of emotions. So, it may not be very easy for people to even identify one strength. And so, I think it's really important for us as clinicians to remember that this is something that could be very buried deep down in somebody, and we have to help kind of elicit this or surface this in somebody. Everybody, no matter who you are, what your background is, obviously has strengths and protective factors, and we may have to help kind of get those out. And so I just want to make sure that we don't forget the strengths when we're doing the assessment, because if we forget them in the assessment, then we're going to miss them likely in the treatment plan and then throughout the patient's time in treatment. All right, so as I stated before, when discussing kind of the golden thread, this, obviously the assessment is this really critical starting point, and it's the foundation of a patient's experience in treatment. And we have to be as thorough as possible in the assessment, because if we miss something in the assessment, then it will go potentially untreated or ignored. And I think we all know this and we understand this, but if we miss something at this very early stage in the process, then it can really be kind of a life or death thing for a lot of people that we work with. And so we have to really focus so much on that assessment and making sure it's as thorough as possible. I know I've said this a couple of times. I cannot stress it enough. I think we all know this, but just reminding people today, for the purpose of this training today, I'm not going to be going so much into detail about the 6 dimensions and kind of the questions that we need to be asking during the intake and assessment process across those 6 dimensions, because I'm assuming that folks have attended the ASAM 2-day training. I'm assuming people have had years of experience doing this, and so we're not going to, spend a lot of time going through those 6 dimensions and, maybe what an ASAM summary sheet looks like. So we're going to kind of just go over some very high-level points about intake and assessment today in terms of documentation that I'd like to go through. So this slide shows us kind of the intersection and the commonalities of the elements of intake and assessment noted in the ASAM text and then the Pennsylvania regulations and the DDAP case management and clinical services manual. So this green box in the middle illustrates all the components of the intake and assessment that overlap with the ASAM text and then the Pennsylvania regulations and the DDAP case management and clinical services manual. So again, that green box is that overlap of all three of the regulations, of the case management and clinical services manual, and of the ASAM text. So you can see kind of that significant overlap. And you'll also see a significant amount of overlap between the ASAM and the case management and clinical services manual. So that's the box that's kind of highlighted in pink, quite a bit of overlap there. And then finally, you'll see the overlap between the ASAM and the Pennsylvania regulations noted in the blue box. So I'm kind of highlighting this because I wanted to point out that I think, even before kind of ASAM entered the picture and maybe even before the case management and clinical services manual ever existed, for most of us on this call, we've always really been gathering this very critical information at intake and assessment. But I think what the ASAM has really done for us it's really helped us to find a way to organize this very complex information that we gather at intake, and it really facilitates a treatment planning process that is more efficient and effective overall. So again, I'm not going to be spending a ton of time today going across those 6 dimensions and the questions that we should be asking, because I'm under the impression that people are very well versed in this, and I'm just going to be going over a few high-level reminders or important points regarding documentation with intake and assessment. Also want to, again, remind folks that we are going to be posting this PowerPoint and, again, the questions that we get and the corresponding answers after the call today. So we're going to, these are, I think, important slides to look at. And as we go throughout the presentation today, there's going to be a couple kind of very busy looking slides. And I want folks to be able to go back to this at the end and share this with their teams and to review it. I do think there's a lot of important information in it, so you will be able to access these after the call today. All right, so intake and assessment considerations. So these are just a couple of reminders about, things we need to be keeping in mind as we're documenting the intake and assessment. So, first on here, I have unbiased. So the assessment should not be biased toward any particular outcome. It should really allow for the patient to be placed in any level along the continuum, even if that level is not offered by the program conducting the assessment. In terms of scope of practice, if the assessment or the treatment planning process identifies issues that are outside the scope of practice and expertise of the assessor, they should seek consultation with the appropriate clinician. So examples of this might be, serious mental illness or withdrawal management or medical concerns. So relying on our interdisciplinary team, so the medical staff when needed, and other folks as well. Facts versus assumptions or judgments or opinions, and then clinical impressions. So these two kind of go together. And so what I mean by this is that clinical impressions are, we're not just kind of regurgitating the data that we heard the patient tell us during the assessment. We are using the clinical skills that we have developed over years of practice in our schooling, in our internships, and our trainings. And we're using our training and our skills to kind of take in this information and then to kind of gauge or provide our assessment of what is going on with the patient, maybe the areas that we need to focus on, some of the blind spots, some of the barriers, maybe some of the areas that might need a differential diagnosis, things like that. So very, very different. So really, judgments or opinions, things like that really have no place. There's really no appropriate place for them to go in the intake and assessment. So just wanted to kind of point that out. Collateral information, I know it's not always possible to get collateral information, but if possible, we definitely need to be relying on that collateral information when documenting the intake and assessment. So that could be former providers, it could be family members, it could be law enforcement, it could be educators, it could be a whole host of individuals. I just spoke about this before, but really looking at the strengths is critical in addition to the risks and the barriers and the needs of the patient. And I have Maslow's kind of hierarchy of needs here. And I was actually on a call, the Psychostimulant Symposium last week, and Rebecca Sedlock from CCBH really spoke to this so nicely. But I love to keep this hierarchy of needs in mind when we're doing the intake and assessment, because, particularly these bottom two rungs here, like the physiological and the safety, thinking about those things that fundamentally, if a person does not have, it's going to make it really hard for them to enter into recovery. So I'm thinking about things like housing, safety, the feeling of belonging, food, employment, transportation, all of those things, really thinking about those fundamental needs that people have, what might be missing, and making sure those are woven into the assessment. Because if they're woven into the assessment, then they're going to be woven into the person's time and treatment. And that is really, really critical. I think I covered all this historical and current information. So, really important to get obviously as much information as possible about that person's history, going back to the time that they were, an infant, and their family of origin and some of those issues, what it was like for them growing up.
Kathleen, excuse me. I'm not sure that we're seeing the same slides that you're seeing. A comment just came in, and I don't think the slides are advancing.
Oh, okay. Show. What slide, Greg? Can you help me? What slide are you seeing right now?
I'm still on number 1.
Oh my goodness. Okay. Let me, folks, sorry about this. Just give us 1 minute while we figure out these technical difficulties here. So
thank you to Bernice for bringing that up in the chat. I appreciate it.
Thank you, Bernice. I appreciate that. Okay. I am seeing you're on slide 9. Diana's seeing. I was seeing the correct slide, I think. Okay, so maybe some people are seeing the correct slide, which is a good thing. And some people were not seeing a correct slide. Okay, so here's what I'm going to do, folks. I'm going to advance to where I was. And if I'm going to go to the slide with Maslow's hierarchy of needs. If you can see the Maslow's hierarchy of needs, can you please type it in the chat? You can just say yes.
So there might be a solution. There was a little box under my slide that said sync with presenter. And
excellent.
when I did that, it went to where you were. So anyone who's was not seeing the correct slide, try that. If you have that little red box right below the slide, okay. and maybe that works.
Oh my gosh, this is great. Okay, so I'm seeing a lot of yeses, some no's. I think we're in the right direction. So thank you, everybody. Sorry about that. Greg, thank you for speaking up. Bernice, thank you so much. I appreciate that. All right, I think we're good. Okay, excellent. Good. All right, just want to make sure that I'm not leaving anything out here. Last thing I want to say on this slide is, and this is something that I was taught very early on, is, throughout doing the intake and assessment so that we don't miss anything, we want to ask periodically, is there anything that I'm leaving out, or is there anything that I'm missing? And you can do that after each of the sections that you're kind of conducting the assessment on, or you can do that at the end. But just asking that open-ended question, and sometimes folks will say, nope, you got everything. Sometimes somebody will say, actually there's this, there are these couple of things that you didn't bring up, and I think it's really important, and I think I need to address it. So asking that question, if not once, multiple times throughout it, so that you can make sure that you're documenting everything that we need to ensure that we're covering all of our bases, and not missing anything throughout the patient's course of treatment. Okay, so just before I kind of go into this, I just want to put another plug into the DDAP ASAM treatment planning training that we have available right now with Dr. Martha Thompson and Stephanie Thorne. This is such a critical training to attend. Please, please, please make a point to do this training and to make sure that your staff is doing this training. I want to make it really clear that a lot of what I'm talking about today is stemming from that training, but it does not replace actually attending that training. So please be sure to do that. So another plug, just make sure that you attend that training if possible. All right, so we're going to be just going over very high level 4 components of a treatment plan. So we have the problem here. So what is the problem according to the patient? Not what is the problem in my clinical opinion or from my personal experience or, all that. And what is the problem according to the patient? And then the goal, where does the client want to go, or where do they want to be? So this is obviously longer term. The objective is how will we know, meaning we is the treatment team and the patient. So it's collaborative. We are staying on the right path so that we can achieve our goal. And then interventions are the steps that we're going to be taking to really sustain progress on and fidelity to our journey. So I'm going to be going into these into more detail here. All right. So treatment planning considerations. And I, obviously can't stress this enough, using patients' own words. I have it there 3 times because it is that important. We must be using the patient's own words in the treatment plan. So we should be using the patient's own words in the problem and in the goal. And if there's one thing that you take away today, it is that we should be using the patient's own words on the treatment plan. Obviously we want to be using all 6 dimensions or addressing all 6 dimensions in the treatment plan. And I think there's kind of this concern that, oh, does this mean I have to have 6 problems on the treatment plan that match each dimension? And no, you don't have to do that, but you certainly can do that. And I do think that there's positives to doing that. I mean, a lot of problems are going to address more than one dimension. So I'm thinking about specifically like dimension 1 and 2, right? Medical and withdrawal. Those are going to kind of often go hand in hand with one another, and they would naturally maybe fit together. So making sure we're addressing all 6 dimensions. There doesn't need to be 6 problem areas to match these 6 dimensions, although there can be. Interdisciplinary. So it should be very clear in the treatment plan, that we are working with everybody that's in part of that interdisciplinary team. So case managers, medical providers, nursing, physicians, I said case managers already, recreational therapists, marriage and family therapists, certified recovery specialists. The list can go on and on about who's involved in that interdisciplinary team, but their involvement should be very clear on the treatment plan, and we're going to be going into that in more detail. You might want to consider using assessment instruments to measure progress. So, using things like the ASSIST or the Beck Depression Inventory or a trauma inventory to measure patients' reduction in symptoms throughout their time in treatment. That can be noted on the treatment plan. We should know who's doing what, which staff is responsible for which interventions. We should be remembering the big picture. So we're not just looking at the treatment episode, we're looking at what happens beyond treatment. And we're obviously staying very patient-centered. So we need to be mindful of a person's age and developmental status and culture and ethnicity and whether or not they're a member of the LGBTQ community and gender identity. I mean, and the whole list of what makes a person an individual. We need to be looking at that and making sure that that's woven into the treatment plan and not ignored. Okay, so this is, I had mentioned before, kind of some busy slides. So we're going to be getting into some of these. I just want to put people at ease, though, because we're not going to be reading directly off these slides. Again, these are going to be available for you at a later date. But what these slides here, I'm going to have these kind of slides for the problem and the goal and the objective and the interventions. And so we're going to start with the problem here. So again, this is what the problem is according to the patient. So what the patient believes has kind of kept them in this pattern. So major points here is that the patient states what they believe the problem is in their own words. We want to avoid labels and diagnoses the patient cannot understand or that they may feel are stigmatizing or shaming. And we want to remember the strengths or protective factors that we've identified in the assessment, and we want to weave those in as much as possible. And we always want to be mindful of how our words can impact trauma in people. So we really need to remember this in the treatment planning process. It can really make a huge impact. Look at the difference between these 2 statements here, right? So we have a non-individualized problem and we have an individualized problem. So it's really incredible the power our words can have and how clinicians can really frame treatment very early on by what we put in the treatment plan. So on the left, we have already, if I'm the patient, I've already been labeled and diagnosed, and I have no idea what that means, or I have maybe a vague sense of what that means, and it's probably not a good thing, and I'm told that I don't have what I need to get better. Not a great starting point. And with the problem statement on the right, the individualized one, the power is really with the patient, and they are the driver, and they're stating very honestly that they don't know if they're an alcoholic, but they do know that bad things happen when they drink. And they don't want to do it anymore. So already the patient has something that they need in order to try to start getting better. And also, just side note, as a huge proponent of motivational interviewing, I mean, there's so much that you can work with this statement, with this problem statement. I would, genuinely affirm the person for their honesty and for being able to see that connection between drinking and bad things happening. And then I would, maybe use an open-ended question, and I would ask them to tell me more about why they don't want to do this behavior anymore, or why they don't want to engage in this behavior anymore. So really a lot to work with here. Okay, so now we're going on to the goal. So this is where the client wants to go, not where I want the client to go, but this is where the client wants to go. So, I want to point out that a lot of the same things that I just talked about in the previous slide, in terms of making sure that we are staying trauma informed, that we're using patient quotes, that we're avoiding labels and clinical terms, all those kind of remain the same here, and those will remain the same throughout all documentation. But a new element here is making sure the goal is realistic. So we can, see very clearly here that on the left, this is not a realistic goal. Why would Raul accept his diagnosis of alcohol use disorder when he just told us before that he doesn't know if he's an alcoholic? And why would he commit to long-term abstinence from all mood-altering substances? I mean, I think this is really assuming a lot. And if you're somebody who has issues with trauma or authority or, whatever, this might really kind of surface some unpleasant emotions or responses, and it's not a good way to start treatment at all. It really starts us off on the wrong foot. It's also just very disrespectful and dismissive of the patient. It's not treating them with dignity and respect, and it certainly isn't giving the patient any power. All right, so this is a slide that I wanted to add because this is something that was really big for me, especially early on as a clinician, and it kind of remained something that I had struggled with internally, is this difference between goals and objectives. And I thought this was a really helpful slide. This is something that I had posted up in front of my desk for years and years and years. But the difference between goals and objectives, if you can see someone doing something, then it's an objective. So writing a journal entry, or if you can see them going to a meeting, or if you can see them exercising, or if you can see them meditating, that's an objective. But if you can't see someone doing something, it's a goal. So the way I like to think about this is that it's kind of an internal shift that occurs in somebody. And so it's kind of this abstract idea. It's not really something that you can physically see. So I probably added the slide because it's more helpful for me, but maybe this will be helpful for somebody that who's doing treatment planning as well. And then, so going into the objectives a little bit more. So again, this is something that you can't physically see happening. It's usually an internal shift in somebody. And so we need, because it's an internal shift, like we need to have these kind of landmarks and ways to make sure that this internal shift is occurring. Obviously we want to be applying kind of those SMART goals that we've all heard about many, many times. So making sure that what we're putting here is specific and measurable and attainable and relevant and time limited. So really there's a kind of a formula here that I like to use. And the formula doesn't always have to be in the same order, but it's the person's name and an action word, what, when, and how it's measured. So you can see here in the example, so very clearly by the second week in treatment, Raul will identify and share with the therapist his understanding of at least 3 social and behavioral and 3 scientific and biological reasons he continues to use substances despite negative consequences. So I also hope this slide can be helpful for people in the future too. I found it to be really, really easy to kind of use a formula like this and to individualize using a formula like this. Okay, so going on to the objectives, again, another busy slide, but just pulling out some key points here. So we want to be using the patient's name. So if we're not using a quote, we're still individualizing it. We're using the patient's name, okay? And we're including a clear what and how. So basically, Raul's job in the first 2 weeks of treatment is to complete all of the interventions related to this problem area so that he can reach this objective or make it to this landmark and meet his goal of figuring out why he continues to drink even though bad things happen every time he does it. Again, just really important. I think the key thing here is to make it as realistic as possible. And to remember to weave in all those things that we had talked about previously, right? So individualizing, we're trying to avoid labels or diagnoses, and we're trying to stay trauma informed. So we're really, this is the patient's, right? So the patient has to agree to all of these things. They have to be directly involved in this treatment planning process in order for this to work and for it to be meaningful to them. And I think that's really, really important. Okay, so going on to the interventions. So those, the interventions are obviously the things that are going to help us obtain this larger goal. So again, another busy slide. And I just want to point out a couple of things here. So the patient should be in agreement with all of these interventions. So they should be, again, directly involved in the development of these interventions. Literally, the counselor and maybe even the interdisciplinary team should be sitting down with the patient and saying, all right, here's our goal. What are we going to do to get here? Here are some thoughts, here are some ideas. What do you think about these? They should be directly involved in this process. They should be trauma informed. They should be, again, mindful of the patient's reading and education level, respectful of cultural and spiritual and gender identity and sexual orientation, and all of these different things when we're putting these together. Assigning interventions that the patient does not agree with or that are not trauma informed, it can be very damaging for a patient's time and course in treatment, and it can be damaging to the person. I'm sure we've all been in some kind of a situation where somebody has assigned us a task before that we've never agreed to, or that maybe we have no idea where it's coming from. It's out of left field, and we know how that feels, and this is really no different. So I was thinking about kind of what the equivalent of assigning an intervention that somebody doesn't agree with would be like in a medical setting. So let's say that you have a cardiologist, right? And they are telling a heart disease patient that they have to start a running regimen when the heart disease patient has clearly stated to the doctor that they don't want to run due to past injuries and they would rather swim or walk for exercise. So the message that the patient is getting when the doctor ignores what they've stated is extremely powerful, and we need to remember that. The likelihood of the cardiology patient being successful if they're engaging in an intervention they've not only agreed with, but actually they've suggested, is the likelihood of it succeeding is much higher. So examples of individualized interventions, I was a little bit hesitant to include this slide because I don't want folks to think, I don't want people to kind of come away with this and say that this is what all interventions have to look like. These are just examples, everyone. And they're just here to kind of get our wheels moving a little bit. So they're examples, and just a couple of things to point out. You'll notice the involvement of the interdisciplinary team, including the psychiatrist and the case manager. And they're very relevant. The interventions are very relevant and evidence-based in the treatment of trauma, and they are specific and they're realistic and they're effective choices. They also state who is responsible to monitor or to facilitate each intervention. I want to stop here, and I want to point out kind of the involvement of the case manager. So I know that the case manager, in terms of the case management and clinical services manual, we make it really clear that case management is a separate and distinct service from treatment, right? And I want to reiterate, that does not mean that it's not such a critical element of someone's time in treatment. It is so important. Case management, in my opinion, can really make or break whether or not somebody's successful once they leave treatment. So I just want to point that out, that although it's separate and distinct from treatment, it is such an important piece of the interdisciplinary team, the case manager is. And so, by all means, case managers, they should be noted on the treatment plan. Their involvement should be noted on the treatment plan as well. So just wanted to make sure that I kind of highlighted that. All right, so finally, we are going to go into some progress notes and some elements of documentation for progress notes. So we're going to be looking at individual progress notes and large group and small group progress notes, and we're kind of going to be going back to the golden thread for a moment to talk about the importance of what we're seeing in the progress notes. Again, it must tie back to the treatment plan and the treatment plan has got to tie back to the assessment. So if I am somebody who is looking at the patient record and I'm seeing something in the progress note that I cannot tie back very clearly to the treatment plan and the assessment, generally speaking, this is a problem and it's not a good thing. So we just have to be thinking to ourselves, and this is something else I was taught, is that if an auditor's, like, if we're writing a progress note, let's think about this. If an auditor is coming in and I'm writing this progress note, the auditor should be able to see in this progress note, like, how what I've done in this session ties back to the treatment plan and how it ties back to the assessment. It should be very, very clear. There should be no, it should not be fragmented. So just can't stress that enough. All right, so in terms of a progress note, on the left, again, non-individualized progress notes, and on the right, individualized progress notes. I have no opinion on what kind of format you all are using in terms of DAP or SOAP or whatever other kinds there are out there these days. No opinion on that. So want to make that clear, but really critical pieces to pull out here are making sure that we're documenting the coordination of the patient's care with the interdisciplinary team. So, you know, with nursing and physicians and case managers and CRSs and the whole gamut, rec therapists, family licensed marriage and family therapists, they should all be, you know, coordination with them should be documented in the progress note. So almost kind of in session, and then as you're documenting after the session, kind of doing a scan of the treatment plan, making sure that during the session, we're kind of touching on all the various components of the treatment plan and getting an idea of how the patient is progressing or struggling in certain areas. And then we're documenting this. And we're asking patients how they're responding to medications, right? So if somebody was started on a certain form of MAT or started on a certain psychiatric medication in the beginning of treatment, we're asking them how that's going. You know, how are they responding to it? What are they noticing? If they struggle with anxiety or poor sleep or cravings, you know, we're directly asking about these things and we're documenting it. We're documenting their response. We're asking how that family session went, or we're asking about how that call went with their probation officer, and we're documenting it, and we're using patient quotes when possible. And we're making sure that we're noting the interventions that we're using and whether or not these interventions appear to be effective. So is the motivational interviewing that I'm using, is that effective? Is the CBT or the 12-step facilitation I'm using, is that effective? And why? How do we know it's effective? And then finally, we're documenting the homework and we're documenting the review of the homework. So lots to consider. And I think kind of the balancing act that all clinicians have to kind of work with is, you know, we have a lot to put in a progress note. We don't want to make it a book. So we, you know, it takes time and practice to really write a succinct, shorter progress note that covers all these areas. And it definitely is possible. It just takes practice. And I think we all know that. All right, just looking at the time here. Okay, so I'm going to go on to small group and process group progress notes. So in terms of small group notes, I mean, basically the same principles that I just talked about with the individual progress notes, you know, they apply here, meaning that they should be individualized and they should, you know, obviously tie back to the treatment plan. And again, I'm just going to go back for a second. So all the things that we just talked about in the individual progress note here should apply to small group process notes. The difference obviously is going to be, you know, we're going to be documenting the patient's interactions with peers. We're going to be assessing those interactions with peers, and we're going to note these. Let's say the patient presented an assignment or offered feedback to peers during group. We're going to be documenting that. If the patient discussed that they could relate to something or they couldn't relate to something, or that something kind of came up for them, we're going to be documenting that in our note. And then obviously the counselor is going to be noting their assessment of the patient's overall response to small group here. And then for the psychoeducational group progress notes, I think there's kind of this misconception that, you know, that with psychoeducational groups, because they can be larger, meaning like there's more patients that may attend the psychoeducational group, that maybe canned documentation or kind of a template documentation is okay to use. So if everybody's kind of listening to the same lecture or watching the same video, the note for everyone can be the same, and that's really not true at all. Psychoeducational groups need to be individualized. They need to be documenting why we chose this specific intervention. So why did we want this person to attend this lecture on this specific topic? Why was this intervention chosen for the patient? And this should tie back again to the assessment and the treatment plan, the patient's response or the feedback to the intervention, and the individualized steps for this patient based on their feedback or response. So I'm gonna probably stray for a second here, maybe a little bit from documentation, but I do think it's related, but into kind of this daily clinical services component. So like, let's say the entire patient census goes to a morning lecture on step 1. First and foremost, we want to make sure that attending a step 1 group makes sense for the individual patient to attend based on what was noted in their assessment and treatment plan. And I would say that we kind of get into trouble if the patient's assigned to an intervention that we can't, again, tie back to the assessment and treatment plan. So it's just something to kind of consider, when we are having like an entire patient census go to one intervention or one group, I think we got to be really, really careful about asking ourselves, is this the most effective use of this patient's time? So obviously something to consider. All right, so just some additional considerations for individualizing notes. So in each note, we should indicate the treatment plan problems being addressed in session. We should note the ASAM dimensions that are being touched on in session. So, there might be some sessions where literally all 6 dimensions are being addressed. And maybe some sessions where all, treatment plan problems are addressed. And we just want to make sure that we're noting that in our documentation. I'm aware that in certain electronic medical records, and I'm going to show you kind of an example of this in a second, that in some EMRs, actually the EMR will pull into the note the problems in the treatment plan or the ASAM dimensions into the treatment plan. And so you just have to check off a box, which is really, I think, very nice. So hopefully that's maybe something some of you have access to. Now, if something kind of comes up throughout, let's say something comes up in a session, an individual session, or something came up maybe when somebody was attending a group and it surfaced something that's significant. So we want to be making sure that if this is something significant and we need to add it to the treatment plan, then we kind of document that in the progress note, and then we might want to add that to the assessment as well. So, we know that happens sometimes, right? So there may be kind of a missing piece that the patient brings up that was surfaced by an interaction with a peer or by a movie they watched or by an activity they engaged in. And so we want to not ignore these things as they come up in treatment that we need to address. Rather, we need to integrate that back into the treatment plan and then into the assessment as well. And then in terms of, you might want to add also a portion to your progress notes where you can put those assessments that I was talking about. So if we're measuring level of craving by using a craving scale, then we want to have a section in our progress note to put what the patient scored that day for that level of craving on that progress note. Same thing for things like anxiety or trauma, or maybe we're documenting a clinical opioid withdrawal scale, something like that. But it may be good to put those assessment instrument scores on the progress notes as well. So I mentioned this is what I was talking about. This is just an example. This is just an example from Los Angeles County of Public Health. But they kind of have an example here of the progress note, and they have the dimensions up top here so that you can check which dimensions were addressed during session. So this is a really, really nice option. And again, I know not everybody has EMRs. I know not everybody has this option in their EMRs to kind of filter in the dimensions or the problem areas. But if you do, you're one step ahead of the game. All right, so just looking at the time here. Okay, so going on to questions and answers. So these are some questions that we received prior to the call today, and we took some time to draft some responses. And so the way that I'm going to be broadcasting these is that I'm going to broadcast the question like this. I'm not going to be broadcasting the response. I'm just going to be talking through the response, and the response will be available kind of on a document at a later date on the ASAM alignment website. So the first question we have here is regarding when a discharge ASAM summary needs to be completed. And a discharge ASAM summary sheet should be completed when a client has completed their entire treatment episode. If a patient is transferring to another level of care, an admission ASAM summary sheet should be completed by the receiving provider. And again, if we will be putting our responses on a document for you to very easily review and read at a later date. So Lisa's saying that she can't see slides any longer. If other folks, if you can see my slides, can you put yes in the chat just so I can make sure? Okay, perfect. Thank you. Excellent. Thanks, everyone. I appreciate that. All right, so what are the ASAM alignment requirements for documentation of non-clinical groups? So I'm going to be kind of veering into the regulations a little bit here, and I think that's important to kind of touch on as we go into some of these other questions. But so DDAP regulations require the presence of a progress note in the client record. However, they don't really detail what needs to be in the progress notes or the content of the progress notes. So when the DDAP Bureau of Program Licensure is coming out to inspect and to maybe do a review of progress notes, they're looking for the presence of progress notes. And what they're looking at is they're comparing the record of service entry with the corresponding progress note. So let's say that it says here, you know, patient A attended individual therapy on October 10th. And what they're looking for is a progress note dated October 10th to make sure that that matches the date of the actual service. And they're also looking at the progress notes to confirm that the therapy is being conducted according to the treatment plan. So let's say the treatment plan says that this person is going to be attending 3 groups a week and 1 individual a week. So what licensing is looking at is they're verifying that there are 3 group notes and 1 individual note per week. And so that's kind of corresponding with some of the regulations that speak to these. So 709.92. And then in terms of what ASAM criteria state, so when you go into the ASAM text and you look at every level of care, there's going to be a little section that has a documentation blurb or a heading. And I really encourage people to take a look at this because it's the same pretty much for all levels of care. And it says that documentation should be, or that progress notes should be individualized in the patient record to clearly reflect the implementation of the treatment plan and the patient's response to therapeutic interventions. The intervention chosen should be related to their needs as documented in that assessment. So really just want to encourage people to look in the ASAM text to see exactly what they're stating. And then folks may also want to be talking to their payers to see what kind of expectations there are related to documentation for both kind of quote clinical and then non-clinical groups. Okay, so how would recreational interventions be documented? So I'm going to probably again stray for a second here, so just bear with me. So I first of all want to point out that that in terms of recreational interventions, and I'm going to use 3.5 as an example here. So when you go into the ASAM text and you look at level 3.5, and there's a therapy section, right? And for those of you who have been on TA calls with me in the past, you can maybe know that this is my favorite page to reference. But on page 251, it really clearly states all the different therapies that are included in those daily clinical services. And one of those therapies that you're going to note is the recreational interventions. And related to that is that at the back of the ASAM text, there's a glossary and there's a definition of something called skilled treatment services. And skilled treatment services, as defined by ASAM, you know, one of the things it includes is recreational interventions. And so the reason why I kind of give this backdrop is because, you know, I just want to point out that there's a very large chance that recreational interventions kind of are considered the skilled treatment intervention, and they can be included in those daily clinical services. And so I would just ask folks when they're considering documentation and who can document and even who can facilitate interventions, you know, a couple different things. So obviously, we want to be paying attention to, you know, will this intervention kind of surface a large emotional response in patients? You know, what kind of training is needed to make sure that this intervention is implemented effectively and correctly? what kind of training is needed to facilitate this intervention, what's going on with the group milieu. If the intervention is going to emote some kind of a challenging emotional response, or if there's a likelihood of it, I would ask yourself, who would be the most appropriate person to kind of facilitate such an intervention? Would that be a paraprofessional staff, or would that be somebody who has more clinical training? So just these are all things to consider. So again, I'm going to go back to kind of this DDAP, the regulations. Again, we don't have regulations that really state what needs to be in a progress note. There must be a progress note, and I would encourage you to, again, reach out to your payers and to kind of see what kind of expectations they have related to documentation, and also be reaching out to them to see what their expectations are about who should be or who's appropriate to be facilitating the different kinds of interventions there are out there. Again, same kind of response here. So DDAP doesn't specify the format that a provider must use. We don't say this needs to be done in DAP or SOAP or anything like that. I would just encourage providers, again, to speak out to their payers, but also to be following their organization's policies and procedures related to documentation, and to be obviously keeping that in mind as well. All right, just looking at the time here. Okay, we're almost done. We just got a couple of slides left here. So there was a question that we received about having patients complete a portion of a progress note for documentation. And again, a DDAP just requires the presence of a progress note. We don't say who can or can't do a progress note, or even if a patient can be involved in the documentation of their progress note. So I would say that is something that needs to be spoken to with your payers. And I would also just add that there are obviously really many elements of a progress note in which it would be inappropriate for a patient to be in charge of documenting their entire progress note. So I think it's a really interesting idea. I think we need to be thinking kind of outside the box in many of these areas. And so I would, again, encourage this provider to work with their payers on it and to find out if there is a way to allow for patients to be involved in the documentation of their own progress notes. And then obviously they want to be also corresponding with their own organization's policies and procedures as well. All right, so this is a big slide. And I wanted to show this because I think this is a really great question that was asked. So there was a provider who asked about something called a daily summary of services form, and whether or not this form that they're thinking about using would really suffice for documentation. And so I have kind of a list here of what's included in this daily summary of services. And I would say that this example, it appears to be in line with individualized progress notes, which clearly document how the intervention ties back to the assessment and the treatment plan and the patient's response to the intervention, and then a plan for next steps. So, I mean, a definite strength here is that it's very individualized. It has an individualized assessment of how the patient responded to each intervention. And clinical observations, it talks about, noting what stage of change they're in, need for modification. So those are our strengths, absolutely. I would just say that, and I don't have all the information about how this is being used, but a concern would be if we are using a daily summary of services form, and if all patients are attending the same kind of lineup of group therapy every day. So let's say that patient A and patient B, they all attend the same groups, like there's no differentiation. I would say that's a little bit concerning in that it leaves little to kind of no room for individualization. So when patients are all attending the same programming every day, that's a problem. And I think I don't really need to go into detail about why that's a problem. So definitely some strengths I see in this example, but just, I don't know exactly how this is being used, but if everybody was attending the same programming every day, that would be the concern here, and there would be very little room for individualization. All right, so what time is it? We have 10:54. So that is the end of the documentation technical assistance call today. I just want to say thank you to everybody who attended. I hope it was helpful. I want to point out that if you have questions related to what we talked about today, or if you need additional technical assistance, please reach out to us via the RA ASAM account. And our next monthly ASAM TA call is going to be on Monday, January 10th at 10 a.m. So initially that was for the 3rd, but because of the holidays, we're moving it back a week for the 10th. And we were originally going to be covering the topic of monitoring, but we are we're going to be doing something different. So I did ask everybody to participate in a poll at the beginning of the chat today. If you have not completed that poll, please do so. And I'm going to see if I can actually rebroadcast the poll here. I cannot rebroadcast the poll. If you haven't already, you can just go back up to the top of the chat here, and you can answer our poll and let us know what you're thinking would be most helpful in terms of what topic we should cover for the month of January. Thank you for joining us again today. We appreciate it. I'm going to stay on the call for another 4 minutes or so. If anybody has any other questions they want to put in the chat, you can certainly do so. And I wish everybody a very happy holiday season.